record on this computer. Did everyone get the questions okay with the 40 questions and the answers that I posted in that folder? Yes? Good. And then did anyone have any issues with those questions? Okay. Sounds good. Well, if you ever do, you can hit me up and we'll discuss it. Okay. Now, okay. Farm. Okay. So here in farm, it's just the basics. We're going to do a lot of math, right? Because farm's a lot of math here at this level. Until you get out of this and then you get to the specific drugs and their mechanism of actions and side effects and stuff like that. But at the very beginning, it's a lot of math that you have to know. Okay. So let's go and go through this. So first thing we're going to do is each drug in general follows these various classifications. Okay. There's the absorption of the drug. Certain drugs get absorbed different ways. Certain drugs you have to inject versus taking them orally because they're peptides. An example of this is something like your GLP-1 agonist. That's the big thrive right now with weight loss, the sitagliptins. Not semaglutide. Semaglutide. There you go, semaglutide. It's a DPP-4 agonist. But anyways, the aspect of it is each drug is kind of falling into different categories, and based on what type of property it is going to affect the absorption of the drug. Okay, so for instance, if a drug is fat soluble, more than likely you're going to have to take it with food, okay, to help with that fat soluble nature of it. Okay, good. Any questions on that before we move on? Let me open up the chat so I can kind of see. All right, good. Now, the next thing is metabolism of the drug. So metabolism of the drug is essentially how is the drug broken down? Okay, so is it broken down in the liver? Is it broken down in the kidneys? Do you excrete? Do you pump this guy out through the kidneys? This is more the metabolism aspect of it. Is it activated first and then does this factor, or does it already become activated when you ingest it, and then when it goes through the liver, it becomes a less active component, and then finally gets deactivated? Okay, so that's more the metabolism of the drug, and we'll talk about that. And then excretion of the drugs. Now, excretion of the drugs is just like what it is. How do you eliminate the drug? Okay, that's it. That's what it is. Now, pharmacodynamics is different. These three things up top is in an umbrella known as pharmacokinetics. Okay, and the bottom one, the pharmacodynamics, is more of what the heck does this drug do? Okay, that's what pharmacodynamics is all about. At the more enzyme function level. Okay, just like enzyme kinetics was all about how you undergo the kinetics of enzymes, how they work, they decrease the activation energy, they have allosteric sides, you got agonist side, antagonist sides, how they look on a graph. All that is the same concept as pharmacokinetics. But pharmacodynamics is more each specific enzyme. What does each specific enzyme do in the body, and how does it work? Okay. Now, drug development, we're going to talk a little bit about that. And then finally, we're going to finish off with a few drugs that you will have to know for your first test. Okay. All right. Let's go. Now, once again, let's talk about just definitional terms. Now, are you going to run across a question that's going to be like, what is the definition of pharmacokinetics? No. More than likely, they're going to ask you, what is the pharmacokinetics of this drug? Or what is the mechanism of action of this drug? Okay. So, in all honesty, pharmacokinetics and pharmacodynamics is to help you just group things into different categories. Group a category into, oh, this is how the drug moves around, this is how it's absorbed, this is how it's excreted, versus this is how it works on the organism. Okay. Now, bioavailability is literally how much of the drug is absorbed into the systemic circulation. So for instance, let me give you an example. If you take an oral drug, right, that oral drug may not 100% get absorbed by the intestine. Okay. Now, on top of that, it could even get partially degraded when it gets to the liver. Now, this partially degraded component is what is known as first pass metabolism or first pass effect. Okay. Now, anything that avoids the portal circulation avoids this. Okay. Does that make sense? Anything that avoids your actual hepatic portal circulation avoids this. Now, examples of this, and we'll get down to it later, is things like orally, your mouth. Inside the mouth, there's certain drugs that you can take that get straight into your bloodstream, bypassing the liver. Or rectal suppositories. If you go below the dentate line, then it's going to get absorbed into the circulation, not into the portal system to go to the liver. Okay? All right. And then this last thing, definition-wise, is known as ion trapping. And we're going to touch on this more and more, but the basis is this. You have cells. Right? And these cells have phospholipid bilayers. Now, these phospholipid bilayers, are they lipophilic or hydrophilic? Or you could say lipophobic and hydrophobic. Which is it? The cell membrane. So this phospholipid bilayer. So this is known as lipophilic, right? Fat-loving or hydrophobic. Okay. Now, the reason why I'm saying that is because in the center, if you remember, are fats. And on the outside, on both sides, are your phosphates that are hydrophilic, right? This is what is known as amphiphatic, meaning it's both hydrophobic and hydrophilic. Okay? Now, with that being said, if you have a hydrophilic, let me go and choose a different color. So let's say you have a drug here, and this drug is hydrophilic. This means the drug cannot pass this fat layer, right? Versus lipophilic or hydrophobic, it can pass that layer. Now, another thing that can play that same factor is positive charges. If you remember, positive charges make something more hydrophilic. Okay? So if something's more hydrophilic, it cannot pass the fat layer. Does that make sense? Okay. Now, that means you have certain drugs that are in either the acid form or the base form. Does that make sense? Okay. So if you're in this acid form, or no, not acid, but base form, this ionized form, this prevents absorption. This is what is known as ion trapping. Because the cell cannot allow this drug to pass the phospholipid bilayer, while as this one can easily pass through the cell. So if you were in something like the renal tubule, this ionized form now gets ended up in your urine, known as ion trapping. Okay? All right, good. So that's exactly what this is here. And we're gonna touch on this again later. Okay, because that's a very important thing. All right, good. So, let me ask you this. If someone overdosed on a drug and you wanted to help him excrete this drug out of his system, would you want the drug to be in the ionized form or the non-ionized form? Perfect. Do not forget that. Because we're going to then start adding on weak base versus weak acid drug. And that's going to help you determine if you need to, A, give something that's acidic and acidify the urine, or B, give something basic to alkalinize the urine to make it more ionized form. Because that's essentially what you're trying to do if you're excreting it. Now, if you wanted to absorb more, you would keep it in the non-ionized form. Okay, good. Now, here's the breakdown once again. You have enteral, parenteral, and then other. Now, enteral is orally, and like we discussed early, this guy goes through the liver, except in some of these areas. For example, rectal, if it's below the dentate line. Okay, or sublingual, because sublingual wise, you go into the venous circulation outside of the liver. Okay, good. Now, parental, this is not going through the GI tract. This is taking a syringe and essentially sticking you with it and injecting it into your body, either via syringe or via an IV line. Okay? Now, with that being said, is this going anywhere near your liver? if you do an IV line, no, perfect. Even if you go intramuscularly or subcutaneously or intraarticular with cortisone injections for osteoarthritis or rheumatoid arthritis or whatever, these guys do not go through the liver. So as a result, the bioavailability, how much of the drug is in the systemic circulation, is always 100%. Does that make sense? Okay, great. So it's always 100% versus here in enteral is always less than 100%. Now, if I wanted to calculate bioavailability, and I always know that parenteral injections is always 100%. So let's say I give a drug that's 5 grams, 5 grams of a drug, and I give it parenteral. That means there's going to be 5 grams of the drug in his plasma, or not plasma, but in his blood. Understand? Now, if I take it orally and then I find out it's 4 grams, then the question is, well, what's the bioavailability of you taking it orally? You would essentially just divide the two. 4 grams divided by 5 grams. Because that gives you the percentage of what was absorbed and ended in the systemic circulation. Because 1 gram was essentially not absorbed or first pass metabolism. Okay? You cannot calculate which one of them is first pass, like how much of that 1 gram is first pass metabolism. You can't do that. Are they going to ask you a question like that? No, they're not. Okay? They're going to ask you questions like, what is the bioavailability? Things like that. Okay? Good? All right, perfect. Now, here we already discussed it, so I'm not going to harp on it anymore. You can see here how, once again, if you do orally, you go through the liver, through the portal circulation, versus sublingual, goes straight into systemic circulation, versus rectally below the pectinate line. That's very important. Below the pectinate line. Because if you go above it, then now you're in the area where it's portal circulation, which also goes through. Okay. Now, that's also known as the dentate line. Either one is the same. All right. Now, here, nothing new. Just going to keep moving on. Here is bioavailability. Now, just like I was discussing with you, okay, it's how much orally divided by how much IV to calculate out bioavailability. And you see that calculation here. Orally divided by IV. Okay? Any questions on that? No? Okay. Now, here's the next thing I want to talk to you about. That's very important. Is this aspect of volume. If you remember back in year 1, your body is made up of 60% water. Okay? Now, we've already talked about bioavailability. So we've already absorbed some mass, some amount into our body via our GI system or via an injection. Okay. Now, what ends up happening is the mass of what you injected never changes. If you inject 5 grams, you inject 5 grams. The concentration changes because concentration is a component of volume. Okay. Concentration is a component of volume. Okay. So if you want to find out the mass of whatever you gave an injection of, you essentially just multiply it by the volume of whatever your vial is to get the mass. Does that make sense? Okay, good. Now, this concept doesn't go away. It stays the same. Okay? This concentration here ends up being the grams or mass that you injected the person with. This here ends up being the plasma concentration, because you can draw someone's blood after giving him a mass. You can draw his blood to see how much of the drug has dissipated in a volume, right? Concentration. And as a result, you find out the volume of the person, or how much volume that drug is in. Okay, does that make sense? Okay, good. Now, with that being said, that's the aspects with absorbing it with bioavailability. Now we're going to we talked about it dissipating in a body of fluid, which is your body. There is more to it than that. For instance, you have extracellular volume or extracellular fluid versus intracellular fluid, and they have different volumes to them. Certain drugs go to certain compartments based on the drug's lipophilic capacity or a drug's hydrophilic capacity. If it's very water dissolving, it stays in the blood and doesn't really end up inside of the cells. Okay? And these are things that we'll talk about as we get a little further down. All right. So, once again, there's different pathways that these drugs can get inside to their various locations. They can do via passive diffusion, lipophilic. Let me do a little smaller. Lipophilic is very important. If a drug is easily diffused and has a huge volume of distribution, the drug is most likely lipophilic. Okay? Now, water soluble do not, just like we talked about. Facilitated diffusion, it just means that you have some kind of carrier protein. And then active, you use energy. So that's kind of a rehash of year one. This one is most common. Can anyone tell me why the first one is the most common? Why is passive diffusion the most common? Yes, drug-wise. Think about it. No, not really metabolism. So think of all the drugs we have out there. We have so many drugs out there that we use, right? And now we're asking these cells to have a specific carrier molecule. So we augment our drug to have the specific carrier molecule so we can attach to. That's way too much work. Way too much work. It's better for us to instead make it so a drug can easily get to where it needs to go throughout the body and not even have to worry about the specific interactions between a facilitator protein and the drug, unless the drug is supposed to attack that target protein. Then we worry about, well, how does that interaction occur? But outside of that, it moving about the body and getting into the tissues, it's harder for you to try to manipulate a protein to do that. It's easier to just make it lipophilic and just move on. Does that make sense? Okay, good. Now, volume and distribution, we already talked about. The amount of a drug in the body, so that's the amount that you injected him with. This is the amount, the grams that you injected him with, divided by how much is in his plasma after you injected the drug. Okay? These two things is how you calculate out volume of distribution. Now, with that being said, remember you got different compartments. Okay? Now, depending on what compartment they can stay in, determines their volume of distribution. For instance, if a drug could only be found in your blood, in your blood vessels, let's say it's something that binds to plasma proteins or something that is utilized in the blood versus the tissues, something like heparin. Heparin is a blood drug, okay? It helps with activating antithrombin 3, and you'll talk about that later. But it's focalized only in the blood versus a drug that is more of a target for, let's say, an enzyme. Which one do you think would have a higher volume of distribution? Something that's stuck inside the blood or something that can go inside the cells and target enzymes? Which one do you think is going to have a higher volume of distribution? So, something that's either inside the blood vessel or something that's supposed to leave the blood vessel, go inside the cells, like insulin, for instance. Let's give a name to this drug, like insulin. Which one do you think has a higher volume of distribution? The blood vessel one that's stuck in the blood vessel, or the one that can get out of the blood vessel and get into the cells? Yes, this one. Perfect. Now, let me ask you another question. Do you think this drug is hydrophilic or hydrophobic? Hydrophobic. Perfect. These guys have the highest volume of distribution versus something that is charged particle or bound to plasma proteins, these have a very low volume of distribution. Okay? Good. Now, my next question to you is this. If you have a high volume of distribution, do you think you have to give more of a drug or less of a drug to get to a desired plasma concentration? If you have a high volume of distribution, do you have to give more or less to get to a desired plasma concentration? Let me show you something. Okay, let's say I want to get to a concentration of 5 in both. This one has 100 milliliters of fluid. This one has 100 liters of fluid. Which one do I have to give more? Do I have to give less in this one? The 100 liters, I'd have to give more. Exactly. And that's the same concept that goes with volume of distribution. So a higher volume of distribution, that means you need to give more of a drug to reach your plasma concentration. Good? Okay. This is going to play on a little bit with what is known as maintenance dose, okay, which we're going to get to later. Okay? Good. Now, volume of distribution, we already discussed. Now, over here off to the right, I made that picture bigger so you can see a little bit better. But essentially, what's going on here is this. They took a drug and they mapped it out pertaining to concentration and how long after the duration and time. Okay? Now, after that, they then said, when does the patient start seeing improvement? When the patient started noticing improvement, this is what is known as MEC. Okay? Minimal effective concentration. All right? This is whenever you first see improvement in whatever symptom you want to improve. For instance, headache with taking Tylenol and Motrin. Okay? You take it at the very beginning, you don't see symptoms the second you take it or improvement of it. It takes time. And as that time passes, the drug plasma concentration is increasing until finally you hit a threshold. And at this threshold, you notice improvement of the symptoms. Okay? Now, it isn't like someone turned off the switch. It's a gradual improvement, which is why you see this. Now, at some point in time, the drug will reach maximum concentration in the blood, which is known as Cmax. Yes. And then at this point in time, you will then start to decrease the drug because of metabolism, because of excretion of the drug into the urine. So that's how this process works. Half-life, yes, also included in there. Great. Half-life, you really start focusing more on, though, when you look at maintenance dosing. How often do you have to take this drug? or how many times before you actually reach the therapeutic range all the time. So, and that's where half-life comes into play, and we'll get there. All right, great. Now, with that being said, the second it passes this line, you no longer have notable improvement in symptoms. Okay? So essentially, our goal as physicians is to keep us above the minimum effective concentration. Because if you stay above that, you will always have a clinical improvement. Does that make sense? Okay, good. Now, this is the other graph you could see. In this graph, this is showing you plasma concentration over time. How this graph is shown is this. At the very beginning of the dose, when you inject the drug, this is injection. Okay? If you remember, bioavailability is 100% with injected drugs, right? However, when you're calculating out the volume of distribution, it's hard to depict what point you use on the graph pertaining to plasma concentration. Okay? Because when you initially inject the drug, it's going to dissipate into the tissues very quickly. Because you got to think, if you have a container and you put a little drop of dye here, it's going to quickly dissipate into the surrounding water until it gets to a point where this water already has some molecules. Then it's no longer going to quickly dissipate or diffuse across the fluid. So as a result, what we end up doing is after you see this giant drop, this is what we would say is that diffusing speed, the diffusion of the drug concentration. We then draw a line backwards, which is this green line, to what is known as our new concentration in the blood. And this is what we use for volume of distribution. Okay? And you only have to worry about this with injected drugs because you have that very quick amount of drugs being dispersed into the body versus something like a oral drug that's not quick like that. Okay? Does that make sense? Okay, good. Now, here's our lovely fluid volumes. Do you need to know this? Heck yes, you do need to know it. Do you need to calculate these guys? Heck yes, you do need to calculate these guys. Do you need to remember which one of these guys is utilized with or measured with what marker? Yes, you do. Okay, so remember, pertaining to things like the extracellular fluid volume, you use things like inulin. Can you measure the intracellular fluid? Can you measure the intracellular fluid? No, there's no marker out there that we utilize to measure the intracellular fluid. Instead, we take the extracellular fluid volume and the total body weight volume, and we minus them to get the intracellular fluid volume. Okay? And that's how essentially we do it. Now, albumin is for plasma, which should be easy to remember because albumin is a plasma protein. Okay? Good? Now, the only one that's still left is total body water, which is a type of water known as deuterium. You use that to measure the total body water. Okay? And those are the big guys you need to make sure you remember and what they measure. All right, good. Now, we've already talked about how protein binding can affect volume of distribution, because if we have something that binds very strongly to albumin protein, that means it's stuck inside of the plasma, versus low protein albumin allows it to then leave the plasma and go into other tissues, which is why you get a high volume of distribution. Okay? All right. Now, here's a little bit with how the kidneys work on it. So the kidneys are really big with absorption and excretion. Okay? Absorption and excretion. Now, on the absorption end of things, it reabsorbs the drug. How does it reabsorb the drug? Via these acid or weak base transporters. Okay? Now, the other way is via the mechanism we discussed earlier with ionized versus non-ionized. Okay? So for instance, if we had a weak acid drug, if you wanted this drug, if you wanted this drug to become ionized, what would you have to do? A weak acid. How do you ionize a weak acid? Or in other words, how do you take this hydrogen and remove it? Yes, you add it to a base. So the base takes that hydrogen away from the weak acid, and now this drug is ionized. Okay? Now, this ionized drug, then, like we discussed, gets secreted outward. Okay? Which is what you see here as this more polar component. Okay? Good. Now, any questions on absorption, bioavailability, volume of distribution? Any questions on any of those? Okay. Now, drug metabolism. Now, with drug metabolism, this is once again the breakdown of a drug. You have two different ways that you break down a drug in the liver. Now, why am I specifying this? It's because there are some drugs that do not get broken down in the liver, but get broken down in the blood. Examples: adenosine. Example: succinylcholine. This guy you will see before your CAS 1. Okay, these are the drugs that do not get broken down in the liver, but get broken down in the blood. Okay, so in the liver, you have two different phases, phase 1 and phase 2. What's the goal of this? Is to make a lipophilic drug, because once again, lipophilic is the majority of the drugs we give. And what do you think is happening to the hydrophilic drugs? Let's say we give hydrophilic drugs, which there are some hydrophilic drugs. We give hydrophilic drugs. What do you think they're undergoing? Since this is for lipophilic. How do you get rid of hydrophilic vitamins? Let's say vitamin C. Vitamin C is a water-soluble vitamin. Why is it hard for you to overdose on it? You pee it out. Exactly with hydrophilic, you pee it out. Okay, does that make sense? So, what do you think is happening when they finish phase 1, move on to phase 2, and they become very polar metabolites? What do you think ends up happening? You pee them out. Okay? You added on an additional thing with lipophilic drugs because essentially you can't pee them out. You cannot pee out lipophilic things because they would easily just reabsorb back into the cells because they're lipophilic. So we need to make them water loving or hydrophilic before we can pee them out. Okay? Good. Now, here are the various reactions. You got cytochrome P450. This is phase 1. Now, in cytochrome P450 or phase 1 metabolism, you have a lot of drugs that increase or inhibit this phase. Okay? Then phase 2 is where you undergo additional processes like conjugation, like acetylation. This is a big one. Acetylation occurs in phase 2. If any of these guys you remember acetylation and glucuronation. Those are the two ones you must remember. And happens in phase 2. Methylation, sulfation, I mean, yeah, cool. But glucuronation, estrogen drugs, birth control drugs, work on that. Acetylation, you can get lupus from acetylation in phase 2. Methylation and sulfation, not really many pharmacological side effects you see. Okay, so let's talk about it. Phase 1, these are your inducers, your inhibitors. You have to remember these guys. You're going to constantly run across these. It never changes. If you ever see one of these drugs pop up on a farm list, and then you see side effects from a drug, more than likely it's because you inhibited or induced cytochrome P450. For instance, if you induce cytochrome P450, Do you think you'll see overdose or under treatment symptoms? Will you see overdose or under treatment symptoms? So remember, cytochrome P450 metabolizes, it breaks it down for you to then pee it out. Yes, so you get under treatment. Versus inhibitors. Do you see overdose symptoms or under? Overdose. Perfect. Exactly. You won't ever get away from this. This will follow you to your grave now that you're a doctor. Okay. All right, good. There are some mnemonics here that you can use to remember them. All right. Let's keep moving on. Phase 2. Now, in phase 2, I said the big ones was acetylation and the glutathione conjugation. Now, why is acetylation so important? Because some individuals genetically are slow acetylators. That means if you give a drug that needs to be acetylated, they have to use a smaller dosage because they metabolize the drug much slower. Does that make sense? Okay, good. Now, within them, majority of it is the Middle East population. Are you ever going to see a question that's like, this person is in the Middle Eastern population? No, you're not. When you get to step 1, you start seeing more questions that hint at these things, such as he went and visited his family in some like Pakistan or something along those, Africa, or he visited his family in Asia, Japan. Those things end up being said in the vignette. But on your cases, during your time now, you're not going to see those questions. Okay. Okay, good. Now, the next thing is people who take drugs that fall into this category that need to be acetylated, if they take them and they overdose on them, they end up in something known as drug-induced lupus erythematous, also known as DILE. Now, drug-induced lupus erythematous presents just like lupus. However, the antibody is different. It's anti-histone antibodies. If you remember when we did that question last time, lupus antibodies anti-Smith. Okay? Anti-Smith is for lupus, as well as a whole bunch of other antibodies. But anti-Smith is a very specific one for lupus. Okay? Good. Now, there are various mnemonics to remember which drugs fall into this category of being acetylators: alpha-methodopa, minocycline, TNF-alpha inhibitors, hydralazine, isoniazid, phenytoin, procainamide, so forth, blah, blah. You're going to have to just remember it. Each time you go over one of these drugs, I advise you to kind of be like, oh, yeah, this is a slow acetylator. Okay? Now, another way they can throw a question at you like this is to show you a graph, and the graph will look like this. Okay? And they're going to say to you along the lines of the drug concentration and efficacy. And you're going to see that one family needs a higher drug than the other family needs a lower drug. This is an example or a graph of acetylators that are different. This one has a slow acetylator. This one has a high acetylator. But they both come from the same population. That's how they ask questions also. Okay? Good. All right. Now, here's the other one with glucuronidation conjugation stuff. It's essentially bioconjugation. The only thing is this drug undergoes that excretion. So it gets excreted in the bile. And as such, it can get broken down by the bacteria in the gut and then get reabsorbed. So these are drugs that end up undergoing enterohepatic cycling. Okay? So this is why certain drugs you cannot take with antibiotics. Or they say if you take antibiotics that it affects how well the drug works. Because let's say you take an antibiotic and now you decrease reabsorption of the drug via the enterohepatic cycling. Are you now under-treating or overdosing? If you gave an antibiotic, killed the bacteria in the gut, decreasing reabsorption, are you going to see under-treatment or overdosing symptoms? Okay. So here's the drug. Okay. The drug gets broken down and then gets reabsorbed via the enterohepatic circulation. Okay. And you also, here, let me move this over. You also orally take the drug. And as such, the drug is at a specific concentration. This drug is excreted via the liver, via the kidneys. Okay. Now, if you remove this one, you decrease the drug concentration in the blood, and you are now under treating. Okay. And that's why people who take things like estrogen pills should stay away from antibiotics, or they should notify their physician about it, because it will affect the concentrations in the body. It will go down and they'll be undertreated, and then they'll get pregnant. All right. Good. Okay, let's move on. What's the answer to this question? What did you guys say? Yes, perfect. Cytochrome P450. Right? He's taking a phenobarbital. Okay. And you see smooth endoplasmic reticulum, which is where P450 resides, right? Drug metabolism. What else does the smooth endoplasmic reticulum do other than drug metabolism? What else does it do? Smooth endoplasmic reticulum deals with lipid metabolism. What else? Hormones, particularly cholesterol. Okay. Steroid hormones. Okay, good. All right, let's take a 3-4 minute break and we'll come back at 6:10 and then we'll do drug excretion and we'll continue on. Sound good? All right. I hope I'm not moving too fast. Am I moving at an okay speed?
I think you're doing good, Doc. I think the speed is good.
All
I
right.
know you're not getting
It,
on here now, John. I just know you're not getting on here
well,
talking. I just
well, you got to
know.
realize. You got to okay. Look at it like this. You got to realize it's just like you had to go to a certain major, and somebody say, okay, you have to learn how to speak English. You understand what I'm saying?
No, I'm saying you're not even talking at all. You meant what you said in the beginning.
No, yeah, yeah. Because like, okay, what's the okay? What's the payoff? Not a lot of payoff from you. I
what's the
mean, like,
payoff? But
okay,
I learned from you. I learned from Micah. I learned from everybody.
I know
So
you
you,
still learn it.
so
Oh,
so
oh,
you not saying nothing is hindering my learning. I'm just like,
no, no, that's all. No, I'm proud of you.
All right, guys. Let's get started. So just reading the chat now. Huh. All right. Okay, so let me go ahead and keep going. So drug excretion. So now that we've talked about the bioavailability, how you absorb the drug, we've now talked about the corresponding components with the metabolism and the P450, the first and the second pass metabolism, excuse me, and how they work, as well as the acetylation and the aspects with the two curves. If you ever see that graph, I guarantee you will more than likely see a graph like that, because many people get thrown off by it. They're like, why the heck is a drug having two different effects on one population at two different drug concentrations. That throws people off. They totally forget about the aspect with the slow acetylators versus the fast acetylators. So don't get tripped up by that if they throw that at you. Now, elimination. This is once again the kidneys or the liver. Okay? Kidneys, liver. These are the two guys. All right? Now, in some places, it is the blood as well, with adenosine and stuff like that, but mainly kidney and liver. Excuse me. Now, this is where you run across this word named clearance. Okay? Do not get scared by this word. Many people get scared of it and they just say, I don't understand it. Let me just remember the equations and move on. They're going to trip you up on it because they know people do that. So, clearance is no different than what you did back in renal. It's the same thing. When you did back in renal, you looked at how much of a drug or how much of a body enzyme or byproduct ends up in the urine from the blood. That's essentially what you did. And you did that by taking the urine flow, how much urine, right? And you multiplied that by the urine concentration. What does this give you? If you take urine flow value and you multiply it by the concentration, what essentially are you ending up getting? The mass in the urine. You're getting the mass of whatever drug or whatever byproduct in the urine. And then you're taking that and you're dividing it by the plasma concentration. So when you do that and you divide by a plasma concentration, what do you think you're going to end up here? Aspects. Is it going to be a mass? Is it going to be a volume? Remember, plasma concentration is grams per volume. So is clearance a mass or volume? Clearance is a volume because you do flipping of it. And as a result, you end up having volume on the top. Okay? So clearance is how much volume is cleared of a mass. Does that make sense now? So when you look at this, you're essentially doing nothing different. Rate of elimination is the same concept. How much you produce urine, the rate of the urine you produce, and the concentration of that drug in the urine divided by the concentration in the plasma. to give you the volume of fluid cleared of the drug. Any questions on that? Can everyone hear me okay? Now all of a sudden all of a sudden I'm getting like no responses. Okay. I think I'm still here. Okay. Well, at least someone responded, so I know that you guys can hear me. Okay. Let's continue. Okay. Okay. So, anyways, we got questions at the end, so I'm not going to harp too much on it. But that's essentially what it is. Okay. Now, with that being said, let's keep moving on. Here is clearance. Okay. The rate of elimination of a drug divided by the plasma drug concentration. Okay. Now, why is this so important? Because you need to know how fast you are eliminating a drug to know how much you need to put back in to the body so you can maintain the same drug concentration in the body. So that's why it's so important to know how much you clear a drug. Okay? Now, another way you can calculate it is this equation, which is the volume of distribution times KE. KE is a constant, and that's 0.7 divided by the half-life. More than likely, they give you this, though. Why? Because they're the devil. And they want you to understand the heck what's going on versus memorizing an equation. That's why. So you may see questions that use the latter, but majority of the questions will be the first. Now, the next thing is half-life. So half-life, what is this? Half-life is essentially how long it takes for a volume, not really volume, for a mass of a drug to divide by half. Okay, so it's a length of time it takes for the drug to have half of it eliminated. That's half-life. So for instance, you have 100% of a drug. Let's say half-life passes. Now you got 50% of the drug. Another half-life passes. Now you got 25% of the drug, which is what this is showing you here. Okay? Now, good on that. Any questions on that? No. Okay, good. Now, let's go on and continue. So here, this equation, all they did was manipulate the clearance equation because clearance used to be here. So they just took half-life and clearance and moved them. So it's the same equation, but they just moved those two. Okay? Now, let's get to dosage calculations. This is how you dose your patient. So, with that being said, you can see how a lot of questions can come from this, because this is a very important thing to know. How much do you give this patient? Okay? So, this is how it works out. The loading dose is the first one. This one's easy. The reason why it's easy is because you know a target dose. Okay? We went over that graph of this, and you had the minimum effective concentration. Okay? And we talked about volume of distribution and on how a high versus a low volume of distribution. Which one do you want to give more drug? The high or the low volume of distribution? Which one of these gets more drug? The high volume of distribution, because once again, remember, when you have a high volume, you need more drug for you to mass that volume. So let me show you. It's fine. I'm happy that you want me to go over this again. So this is what's going on. Okay, that's why you need a higher volume, right? When you have a high volume of distribution, you need more mass. Okay, more of a drug. Now, okay, so now you know your target dose, because your target dose is essentially the minimum effective concentration. Okay, so what you end up doing is you end up just multiplying the two together. If you know this is the concentration in the plasma that you need, and you know the volume of distribution, what's concentration? Concentration equals mass over volume. You know your plasma mass, you know your volume. Now, that's how much you give. Does that make sense? Volume times concentration, because this plasma is your concentration. Now, that's why in this equation, you see this, which is essentially what we just discussed. Okay? Now, they added this piece, F, which is bioavailability. The reason they did that is because some drugs are orally taken in. Excuse me. Versus some drugs are IV. If this was an IV drug, would you need to have bioavailability there? No, because it's always 100%. Exact, perfect. I love it. Good, 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 good. Since you have some portion not getting absorbed, you have to account for that. So my next question is this. If you take a drug orally, does that increase or decrease your loading dose? If you take a drug orally, does that increase or decrease your loading dose? So you take a drug orally, it goes through the liver and ends up in the systemic circulation, right? However, in the systemic circulation, it's less of a drug than what you originally took. So as a result, you need to take higher drug. Let's say you're looking for 5 grams in the systemic circulation. Okay. So if you're looking for 5 grams of systemic, if you took 5 grams, it would get down to 4 grams because of the liver. So you have to instead take 6 grams. So by the time it goes through the liver, you end up with your goal of 5 grams. Okay. So you increase it when it's done orally. That's why bioavailability is here on the bottom. Now, let's talk about maintenance dose. So here's the graph. Let's say this is 100%. This is 0. When you take a drug, okay? But yet, let's not do that. When you take a drug, okay, you first reach 100% of the drug reaction. Okay. However, over time, it will divide by half due to half-life. Right? So now you're sitting at 50%. Does that make sense? Okay, great. Now, let's do grams. Because I think if I do 100%, you guys are going to get confused by how is it higher than 100%? Let's just do 100 grams. Okay. Now, you take the dose again. So 100 grams plus 50 grams means you're now at 150 grams. Does that make sense? Okay. Now, your half-life then happens and it drops to 75. Does that make sense? And then you take another, and now you're at 175. And then half-life happens and it drops. But this time, it's around like 80 something. And then eventually you take it again, and then it comes down. And then you'll get to a point. You see how we're getting closer and closer to having 100 grams at your stable. Does that make sense? Now, if I affect this, which is your half-life or how fast you clear the drug, if I increase this, do I have to give the drug more or less? So let's say this is 1 hour. And then in another hour, yes, we have to give it more. So clearance of the drug takes precedence. Perfect. Now, eventually you end up hitting what is known as steady state after 4 to 5 half-lives. This is important to know. It takes 4 to 5 half-lives before you reach the stable state. Okay? Now, that means if you...
Question.
Yeah, go ahead.
Sorry. So is the half-life, or you say are clearing? So
Half-life is so the half-life here is a combination of the half-life and clearance. Because if you remember,
yes.
the equation has clearance in the denominator.
Okay, I just want to make sure that I can put them together. I don't want to get it
Yeah.
mixed up. So
Yeah. So that's why it's a part of it. Okay. Because if you increase clearance, you decrease the half-life. So you, just like we were discussing, you have to give more drug. Because by the time 1 hour now passes, let's say if you decrease it to the point that half-life is 30 minutes, that means by the time you reach an hour, which is where you would have gave the drug, he's already gone down 75% of his drug versus 50. Okay, so that's why you have to take clearance into consideration here. Yes, perfect. Now, so with that being said, half-life, clearance, okay? Now, it takes roughly about 4 to 5 half-lives before you reach steady state at a baseline. So you will always, at that point in time, be at 100 grams. Now, if you decide to stop the drug, it goes the same process, but in reverse. So what I mean by that is this: if you stop the drug, your first half-life will be back down to 100 grams. Like, let's say you took the drug and you're like, all right, I'm going to not take the drug anymore. So the first drug is down to the half, and then it'll go down to the 50. Okay? Does that make sense? And then so on and so forth. That's why sometimes you can miss a dose on certain drugs. I'm saying certain drugs, and you're still at the same okay range. All right? Okay. Good. Now, do I advise that? No. Now, let's continue. So, now that we've talked about that, the other thing that takes component in this is time. Time takes component because you need to know how often you're giving the drug. Here, we're giving the drug every hour. But the reason we're giving the drug every hour is because the half-life is every hour. Okay? Now, does that mean that you're always going to be staying on the half-life? No. Because what if the half-life's an hour? Then instead, it would be better to just do 2 hours. You give one dose that compensates for both hours and brings you back up to where you need to be. Okay? So that's why the duration of time between doses also takes precedence here. All right, let's keep going. They're complex concepts. We're going to talk about it more. This here is talking about the same thing we were just discussing. This is your half-lives. It goes up, you give a new drug, went down with half-life, you gave the drug again, it went down with half-life, you gave the drug again, went down with half-life, and you can see now you've hit a point where it's basically the same and is not changing anymore after 4 to 5 half-lives. 1, 2, 3, 4. Okay? Good. Now, here they're talking about how the drug can be eliminated. That was half-life. Okay? There's different rates of elimination pertaining to metabolism in the liver. Okay? So, here are the way they're broken down. 0 order versus first order. 0 order essentially is just saying that this drug is not affected by concentration. Okay? So the drug could be as high of a concentration it wants to be. No matter what, the drug will always be reduced by the same amount. So for instance, you have a drug that's 500 grams. And let's say every half-life, you lose 4 grams. That's always that way. Even if you have 1,000 grams, even if you have 10,000 grams, it's only 4 grams removed per half-life. Okay? Now, first order elimination takes the concentration into its calculation. So as a result, when you have 1,000 grams, you eliminate more than if you had 10 grams. Good? All right. Now, you do have to know what drugs fall into them. Just know P. PEA. These are the 3 main drugs that undergo zero order elimination. If you know that, all the rest are first order. Okay? Phenytoin, ethanol, aspirin. This we've already discussed, so I'm not going to talk about it anymore. This we haven't. So the next thing we need to kind of tack on to this excretion process with the urinary system and weak bases versus weak acids, we already talked about how the ionized form gets trapped and you pee out the ionized form, while the unionized form gets reabsorbed back into the blood. Okay? Now, with that being said, this is a graph to know how much is ionized. So you know how much is excreted. Like let's say, for instance, a drug had a pKa of 9.2. Okay? If a drug had a pKa of 9.2, at pKa, if you were go back to, oh my God, at pKa, if you go back to year 1, you have equal numbers of base and acid. They're equal at pKa. Okay? Now, if you go above or below, it'll change it. It'll skew it to make it so you have more base or you have more acid. Right? Okay, so now we're looking at a weak base here. So if we're at pKa, we're equal. We equal to base and acid. If we make it more acidic, if you remember, here's a base. Okay, here's the base. If we make it more acidic, what's going to end up happening? We're going to take away more hydrogens to make it into this form. Which is why you get more ionized form. Okay? If it's a weak acid, so now you're more in this format. Then you make it more basic so you could rip that hydrogen off and make it more ionized. Does that make sense? Okay, good. Now, Beer's criteria is also something that's very important to know. Essentially, what you're looking at with Beer's criteria is you're trying to minimize drugs that cause hypotension, falls, bleeding, and C. diff. Okay? These are the 4 things you want to minimize as an elderly individual. Because when you're elderly, you have multiple drugs, right? And multiple drugs, it's hard to manage what drugs to remove. That's why they came up with this thing known as the Beer's criteria. Okay? Good. Now, let's focus on these questions, and then we'll move on. So here in this one is asking, what is the most likely half-life of the drug? What was your answer? We know the volume of distribution, 40 liters. We know the clearance, 2 liters per hour. So what do you do with these? What do you do with volume of distribution and clearance? There's an equation we talked about that you use both of these to calculate out the half-life. Yes, you divide the two. So you do 40 liters times 0.7 divided by your clearance. And as a result, you get your answer. Okay? Any questions on any of this? Now, did anyone calculate it out? Tell me what the answer is so I can clarify for you. See how well you did on your end. Yes, perfect. See, good stuff. 14 hours. Now, next question. They're asking you, what percentage the initial dose of the drug will most likely remain in his body 6 hours later? So what are they asking for here? They want to know how much drug is going to be left in his body after 6 hours. So what do they want to know? The half-life. Perfect. Yes. They want you to calculate, they want you to use the half-life to find out how much drug is left. Now, the half-life of the drug, gentamicin, is 3 hours. So now 6 hours. So if you're at 100%, I'm going to be honest with you, with these half-life questions, just draw it out. Just draw it out because it's going to be so much easier for you. Okay? So if it's at 100% and you have 2 half-lives, first half-life, you're at 50. Second half-life, you're at 25. Okay? So now what's remaining is 25. Be very wary of this. The only reason why I say that is this. Instead of saying most likely remain, they could say most likely removed. And then the answer would have been 75. Okay? They could easily just change one or 2 words. So you gotta pay very close attention when you run across these half-life questions. Do you want to know what's left, or do you want to know how much is gone? Okay? Good. Now, here's our next question. And our next question is asking us for the loading dose. Now, when you do loading dose, what is a big player? Loading dose is just a single dose you give them. You give them a single dose to reach that, if the minimal effective dose, that minimal effective concentration. Okay. So you give them one dose so you can reach that, versus doing a whole bunch of small doses to reach minimum effective dose. Now, do you remember what goes into this calculation? If you're trying to figure out how much to give at one moment in time, do you think clearance is important? How fast you're peeing this thing out? No, it's not important. The reason why it's not important is because you're just giving one dose to reach minimal effective concentration. If you wanted to give multiple doses, then I say clearance is very important. But you're just giving one dose. Why are you worried about how fast he clears it out? Are you going to give him another dose? And that's why you want to know that? Yeah, exactly. If it's one dose, you don't need to worry about clearance. All you need to worry about now is how much volume he has and what is your target. Because you take these two, you multiply them together based on if there's bioavailability, and that's your loading dose. So for instance here, your desired serum concentration is 20. So that's your target, 20 milligrams per liter. And here's his volume of distribution. Now, they threw a wrench in this because they didn't give you his whole body volume. They gave you a ratio where you have to take this and multiply it by his weight. And then as such, you get his volume of distribution. 75 times 0.5, which would then be multiplied by 20 to find the loading dose. Does that make sense? Okay. Yes, you had to find the volume of distribution, and it ends up being 750. Okay. Now, here's our next one. What are we doing here? Is we're taking which of the following doses should be administered IV every 8 hours. So, every 8 hours. This is something that you're giving multiple times. Do you think clearance is important? Yes, it is important, because if you're clearing things faster, I need to know. Then if you're clearing things slower, I can give you a lower dose. Exactly. So clearance is a part of the equation. So with that being said, we know our steady state is 4.5. We know our volume of distribution is 0.5 liters per kilogram. And they're giving us our clearance, 0.5 liters per minute. Now, my next question is this. If you're giving a drug over multiple times, does it matter how big the volume is? So let's say this again. If you're giving the drug multiple times, does it matter how big of a volume you have? Think about it. We have a big volume. Let's say we have two volumes. One volume is 100 milliliters. One volume is 100 liters. Okay? Now, we're not doing loading dose. We're doing maintenance dose. Okay? In maintenance dose, it doesn't matter how much volume you have. And let me explain why. Okay? When you give a dose, let's say of 100 grams, okay? You give this dose here, you give this dose here. Yes, here in this volume, the concentration is lower. I'm not disputing that. But what's your goal with maintenance dose? Your goal is to keep whatever target concentration you want to be the same. So no matter how much it drains out, the actual concentration inside the vessel stays the same. That's your goal, to have in equal to out. When n equals out, you're good. That's your maintenance dosing. Okay? Does that make sense? Perfect. So with that being said, volume of distribution is not something you need here. Instead, you need clearance, you need your target dose, and you need how often you're giving it. These three multiplied together okay? Good. Any questions on any of that? So with that being said, what answer do you get? What answer did you get? Mind you, this is in hours. This is in minutes. So you have to augment the numbers. You end up with E as your answer. Okay? Good. Now, here's our next question. And this is essentially asking us, which of the following changes in urinary pH in serum potassium will occur if sodium bicarbonate is administered to the boy? Okay? So they tell you that this thing is an acid. 2,4. So we have an acid. We're giving a base. What is the form of the acid? Is it ionized or non-ionized? Yes, it's ionized. Perfect. It's becoming HA and becoming A minus. Great. So that means we're increasing the excretion. Okay. Now, they also want to know what's happening to serum potassium when if you give sodium bicarbonate. So with this one, it's a little bit more complex with potassium, but essentially you're looking at the hydrogen ions. If you remember back in urinary, when you increase the hydrogens outside, they flow inwards into the cell for buffering, and potassiums leave the cell. Okay? But if you do the reverse, you decrease the hydrogens because of sodium bicarbonate, that means more hydrogens leave to join the tissues, and potassiums then go into the cell. So as a result, serum potassium should decrease. And urine pH will increase because of being sodium bicarbonate. Does that make sense? Okay, good. Now, let's see here. Let's finish up the rest of this, because I'm trying to think here. How do I want to play this out? You know what? I could probably knock out pharmacodynamics, because pharmacodynamics isn't as rough as you may think it is. Yeah, I could probably knock out pharmacodynamics quite fast. Okay, so pharmacodynamics. Do you guys need a break, or are we good to keep going? This is only going to take me like maybe 10 minutes. Okay, so pharmacodynamics. Remember, this is breaking down like how the drug is. Is it an agonist? Is it an antagonist? Is it increasing the efficacy or decreasing the efficacy? Right? How is it affecting your biological enzymes or your biological response? Now, you got different types. This is a throwback to year one with enzyme kinetics. You got competitive inhibitors. If you give a competitive inhibitor, does that increase or decrease your Km? It increases the Km. Perfect. Just like with drugs, it takes A, which is the normal agonist by itself, and it increases the Km, also known as the potency. Okay, so you need a higher amount of the drug to reach the same potency. Okay, so here we would decrease the potency. Just like when we looked at enzymes, if you increase Km, you decrease affinity. Okay, good. And Vmax stays the same. Now, how high it goes, how high it goes is known as efficacy in the drug world. Okay, so Vmax for enzymes, efficacy for drug pharmacology, but it's the same concept. And you see that here. We gave an agonist, or we gave an antagonist, a competitive antagonist, and Vmax or efficacy stayed the same, but the potency decreased because we need a higher dose. Okay? Now, the second one I'm going to talk about is what is known as an allosteric activator. This is no different than what is known as a allosteric when it comes to a non-competitive inhibitor, my bad. A non-competitive activator or inhibitor. But in this sense, it's a non-competitive activator. Now, when you did non-competitive, what changed? Vmax. Km stayed the same, right? But Vmax changed. Same concept here. Efficacy changes, Km stays the same. Okay? So potency doesn't change, but the efficacy of the drug does. So now my question is this. Is it better to give drug A and C together or drug A by itself? A and C together. Perfect. Good. Now, that same thing that we just talked about are the different types of drug interactions. You can have synergistic drug interactions, which is what you just examined with A and C. You added them together and you had a bigger response than what you originally had with A, or C by itself. Now, you also have things like permissive drug reactions or permissive drug interactions. This is when something is needed for you to utilize a certain hormone. An example of this is back in year 1, cortisol with catecholamine production. If you remember, cortisol activated the enzyme that took norepinephrine and changed it into epinephrine. Also, cortisol was the guy that increased the adrenergic receptors, being alpha-1, as well as some beta on the actual membranes. Okay, so that's known as a permissive drug interaction. Okay. Good. Now, regulation. How do we regulate or augment this receptor aspect of things? Because now we're actively at the receptor. So, 1, the receptor can become more sensitive or can become less sensitive. This is more likely. Okay? The reason why this is more likely is because we're giving the drug. The only time this happens when we're giving drugs is pertaining to blockers or antagonists. When you antagonize, you block it, and as a result, you upregulate, you increase the sensitivity to that particular ligand. So, an example, beta blockers. Beta blockers block beta 2 and beta 1 receptors. And as a result, your body will start to upregulate beta 2 receptors to find epinephrine. Okay, this is an example of increased sensitivity. Okay, now decreased sensitivity is a majority of the time what we run across. Okay, now there's three different ways. One, we can decrease the number of receptors. We can decrease the affinity of the receptors, which makes sense. Or we can undergo something known as arrestin. Once again, this is a yell back to year one. You can silence the receptor, which is what beta arrestin does. Okay? Now, the last thing that can occur, which is known as tachyphylaxis. Now, tachyphylaxis is a very unique thing. What I mean by is this. Let's take, for instance, nitric oxide. Okay? Nitric oxide is a compound that you produce to undergo vasodilation. Right? It goes to the various smooth muscles around the arteries and causes vasodilation. Now, there are various drugs, particularly nitrites, that augment this process. However, eventually over time, you will run out of nitric oxide and you will not be able to undergo vasodilation. If you increase nitrates in this regard, will anything happen? You ran out of nitric oxide. No. This is key to tachyphylaxis. Okay? It's whenever you increase a dose of something and you still don't have a result. Okay? That's tachyphylaxis. Now, here, talking about efficacy again, talking about potency again, nothing different there. Once again, nothing different. This here is something that is very important to understand, though. Partial agonist. So, partial agonists play at a different role. What I mean by is this. If you have a receptor, here's my receptor on my membrane, and you have agonist A, that if it binds, you get 10 cyclic AMP, and then you got partial agonist, that when it binds, you get 5 cyclic AMP. What do you think will happen if partial agonist binds pertaining to efficacy? How well the drug works. Will it have a higher efficacy or a lower efficacy? A lower. Now, if this partial agonist is taking up this spot, can an agonist bind? No. This is the concept of how partial agonists in the site of agonist drugs acts like an antagonist. Does that make sense? Which is why whenever you look at the graph, it shows up as a non-competitive antagonist. because the efficacy has decreased, because the partial agonist has blocked the spot, doing a less reaction, so the full agonist cannot bind. It's blocked out of the spot. Okay? Now, we've already talked about how competitive antagonists work. This here is just showing you how partial agonists, you reach a roof. And the roof is known as this thing here, where no matter how much partial agonist you give, you will never, ever reach the strength of a full agonist. No matter how much of a partial agonist you give. Okay? Good. Good. Now, this here is now looking at side effects. So we've talked about dosing, but we've yet to say anything about adverse effects. Now, there's a certain dose when adverse effects start to pop up. Okay? Now, adverse effects in its entirety just means unwanted drug symptoms. So, for instance, this is an example. Someone who is, let's say, bee sting, and you do an epinephrine pen. Okay, the epinephrine pen causes you to open up your bronchioles, causes you to increase your heart rate, causes you to increase contractility and improve symptoms, right? However, if you give the same drug to someone, let's say, who is not in anaphylaxis, you get palpitations. Now the same symptom is a side effect. Okay? So it's an unwanted drug symptom. Don't tag it as this is a side effect always. Okay? It's based on what they're being treated for symptomatically. Okay? Make sure you remember that. Okay? Because then a side effect could essentially be not a side effect, but the symptom you're looking for. Okay? Good. Now, with that being said, these other additional symptoms tend to pop up the higher the dosage. Okay? For instance, here we see the adverse effects, and here is the therapeutic range. Therapeutic range is no different than that minimum effective concentration that we discussed. Okay? So, as you increase the drug concentration, you do get increased efficacy. Which makes sense, because if you looked at that graph that we looked at earlier, here's our graph, it went up to a max and then went down. And minimum effective concentration was down here. So efficacy does increase with higher dosage. However, you see here, there's a space between the 50% range of therapeutic and the 50% range of adverse. What that 50% means is 50% of the patients or people that were given the drug had symptoms. That's what that means. Okay? 50% of the people who were given the drug had improvement of symptoms. Okay? So that's where this here comes into play. LD 50, lethal dose 50 over effective dose 50. This gives you your therapeutic index. Now, if you have a high therapeutic index, what do you think that means? Yes, more room for error. Why that is because this lethal dose is moved far to the right. Because this number has to go up for you to have a higher therapeutic index. Does that make sense? I love John answering the questions, but I just want to make sure, right, that the basis for you guys, that the lethal dose, when it goes up, it's higher range because we're moving the lethal dose to the right. And because of that, your therapeutic index goes up because the top number is now bigger. It's 50 instead of 25. Okay? Now, if the lethal dose goes down, what happens to the therapeutic index? If this lethal dose goes down and goes to the left, what happens to the therapeutic index? Does it go up or does it go down? Perfect. It goes down because now you have a lower number up top. So the therapeutic index goes down with it. Great. Okay. So with that being said, the last I'm going to say is this. Do you want now a higher potency drug or a lower potency drug? Do you want a higher potency or a lower potency? To minimize adverse effects, which one do you want? Okay, so if you have a lower potency drug, what does that mean? That means you need more of a drug, not like dosing wise, before you reach ED50. Okay, so essentially what you did is increased ED50. When you increase ED50, what happens to your therapeutic index? Does it go up or go down? So you're dividing by ED50. Since you're dividing by ED50, it goes down. Okay? So your therapeutic index goes down, meaning you have less wiggle room before you reach adverse events. Yes, perfect. It's more dangerous. Essentially, what you did is you took this graph and you moved it to the right. So instead of it being at the yellow marker, it's now at the blue marker. And you see how small of a therapeutic index you now have. It's so close to having a lot of adverse events. This is why you want high potency drugs. Okay? High potency drugs gives you more wiggle room. Okay? Good? Any questions on that? All right. Tell me the answers that you said for these guys. Best explains these laboratory findings. Laboratory serum studies show lower than expected levels of theophylline. Current medications include theophylline. He's not missed any doses. He's not taking any herbal supplements. Why the heck is his theophylline lower than normal? So the big one here is you have enhanced liver metabolism. Why do we say he has enhanced liver metabolism here? Alcoholism. Okay. Chronic alcoholism increases cytochrome P450. Be careful with this though, because acute alcoholism decreases cytochrome P450. Be very careful with that. High chronic, you get a lot. Acute binge drinking, you have low cytochrome P450. All right, good. Last question. We see here, if the dose of the study drug is doubled, if the dose of the study drug is doubled, which of the curves below is most likely to occur? So here's the drug, and they doubled it. They want to know which one of these, A, B, C, or D, is most likely to happen. Now, they have here saying that the experience is with no drug administered is B, is the blue one, right? No drug. And then the red one is the drug. What you guys say? You doubled. If the dose is doubled. So the big thing is you have to get here is you see here no drug to the drug. This is what is known as a partial agonist. We know it's a partial agonist because the efficacy is lower, but Vmax, oh, not Vmax, the KM or potency is the same. So what's going to happen if you give more partial agonist? You're just going to block more receptors from the true agonist. So that means you're just going to have a lower efficacy. A. Does that make sense? But that's why. First, you have to identify what the drug is doing. The drug is a partial agonist. Now, if you double a partial agonist, what happens? You just do more antagonistic effects. All right, guys. So we're end there. We're gonna do drug development and the rest on Thursday. And it's literally just talking about biostats type stuff. Phase 1 versus through phase 4. Nothing really big. It's just more memorization. And then I'll talk about some key features of different drugs on Thursday. And then that'll be it. Thursday, there's going to be a lot of math. There's going to be a lot of these questions. Okay? So really attempt those before coming on Thursday. Because I guarantee you, if you attempt them and I walk you through them, you're going to see them, you're going to get it down. Now, this is kind of like biostats. Okay? I'm being real with you. This is kind of like biostats. You can do it now, get it good, but then a majority of people don't look at it anymore until around test time. And then they look at it again. And then they have to relearn it pretty much. So what I'm urging you to do is understand. Don't do them just to get them right. Understand it so you won't have to come back to understand it again. You will already understand it. Okay? That's my advice to you with like pharmacokinetics and stuff like that. When you get to the actual drugs, you got to remember it. But here, understand it. Understand what clearance means. Understand what bioavailability. Understand partial agonist, how that affects. Why is it just the Vmax and not Km? Okay? Good. All right, guys. So I won't harp on you anymore. I went over a little bit. I do apologize on that, but it is what it is. I'll see you guys on Thursday. We'll do questions. I'll post the questions for Thursday, and then we'll do them. And if you have any questions about the 40 questions that I gave you, please don't hesitate to ask. I will go over them with you. Just tell me the numbers. You have the questions now, so you can tell me what numbers. And then we'll be good. All right, guys. Bye.